Evaluating a patient for major thoracic surgery is one of the more complex challenges we face. In this presentation, we're going to break down this systematic, evidence-based framework for preoperative risk stratification, specifically for those patients who will require one lung ventilation. The goal here is to take these comprehensive guidelines and turn them into a clear, structured approach that you can use to enhance patient safety and really clarify this crucial concept of functional operability. We'll be following the framework laid out by the European Respiratory Society and European Society of Thoracic Surgeons, the ERS/ESTS guideline. It gives us a very solid three-step model. We're going to start with respiratory mechanics using spirometry, then we'll assess the lung parenchyma with DLCO, and finally we'll look at the body's total cardiopulmonary reserve with CPET. After that, we'll pull it all together into a complete risk profile, and most importantly, connect all these preoperative findings to our intraoperative strategy. All right, so our first step is the absolute foundation, evaluating respiratory mechanics. Spirometry is the mandatory, non-negotiable first-line test for every single thoracic surgery candidate. It gives us that essential baseline data on the mechanical properties of the patient's respiratory system. To put this into context, let's think about a very common scenario. You have a patient scheduled for a lobectomy. The first and most fundamental question we have to answer is, how do we differentiate between an obstructive and a restrictive pathology? Well, the key to that initial stratification is a correct interpretation of their spirometry. This table really breaks down the patterns we're looking for. Now, the diagnostic pivot point here is the FEV1/FVC ratio. If that ratio is below 0.70, you've confirmed an obstructive defect. You'll often see that visually as a classic concave or scooped shape on the flow volume loop. On the other hand, a restrictive pattern shows a proportional drop in both FEV1 and FDC. This gives you a normal or even high ratio, and a flow volume loop that looks normal in shape but is just smaller. Let's be absolutely clear on this. An FEV1 over FVC ratio below 0.70 is the definitive diagnostic threshold for an obstructive lung defect, like COPD. You could argue this single value is the most critical piece of information from that initial spirometry because it immediately points us down the right path for further investigation and preoperative optimization. Beyond just the diagnosis, we have to quantify what the functional impact of the surgery will be. We do this by calculating the predicted postoperative or PPO FEV1. The standard formula, as you see here, is based on a 19-segment lung model. Now, a PPO FEV1 that comes in below 60% signals moderate risk, and that means we absolutely have to proceed to the next level of assessment. If that value is below 30%, we're in high-risk territory, and that requires mandatory advanced functional testing, specifically cardiopulmonary exercise testing. So that brings us to the second and equally important leg of our assessment, evaluating the lung parenchyma itself, the actual tissue that does the work. We're moving beyond simple mechanics now to the integrity of gas exchange. And for that, the diffusing capacity of the lung for carbon monoxide, or DLCO, is our most sensitive clinical marker. The DLCO gives us a number that represents the lung's ability to move gas across that alveolar capillary membrane. It's such a powerful tool because it reflects the health and the total surface area of that interface. This is often why DLCO can be a better predictor of post-op complications than FEV1. It's measuring the loss of the gas exchange surface, which is physiologically much more significant than just the loss of mechanical volume. Now, this slide highlights an absolutely critical clinical pearl. When you see a disconnect between normal mechanics and poor gas exchange, meaning normal spirometry, but a low DLCO, that is a major red flag. This pattern points to a pathology in the lung parenchyma or the vasculature that is completely invisible to spirometry. It should make you immediately think about conditions like pulmonary hypertension or early interstitial lung disease. Just like with FEV1, we use both the preoperative and the predicted postoperative DLCO for risk stratification. As you can see, a PPO DLCO over 60% is considered low risk. But the really crucial threshold is a PPO DLCO below 40%. This signifies a high to very high risk for major postoperative complications. It makes cardiopulmonary exercise testing mandatory and requires a formal multidisciplinary team discussion with your surgical and pulmonary colleagues. Okay, let's move to the third and final piece of our assessment, evaluating the integrated cardiopulmonary reserve. When our initial tests are borderline or concerning, cardiopulmonary exercise testing, or CPET, is our gold standard. It is the ultimate decider of a patient's physiological ability to actually withstand the incredible metabolic stress of a major thoracic operation. Now, while formal CPET gives us that precise measurement of maximum oxygen consumption, or VO2 max, simple functional tests can be really valuable surrogates. The stair climb test is a classic example. If your patient can climb 5 flights of stairs, that correlates pretty well with a VO2 max over 20, which puts them in a low-risk category. On the flip side, if they can't even manage a single flight, that strongly suggests a VO2 max below 10, which often means the risk of major lung resection is prohibitive. This chart shows the definitive VO2 max thresholds from the guidelines, and these numbers have direct, serious implications for surgical planning. A VO2 max over 20 milliliters per kilogram per minute means the patient likely has enough reserve for any resection, even a pneumonectomy. Between 10 and 15, the risk is much higher, and only a limited sublobar resection should be on the table. And a VO2 max below 10 milliliters per kilogram per minute, well, that's widely considered a contraindication to a major anatomical resection. So we've examined all 3 core components. Now it's time for the synthesis. The ERS/ESTS guideline uses this idea of the 3-legged stool model, and it's a memorable and clinically powerful concept for ensuring we're doing a truly integrated and comprehensive risk assessment. The central metaphor is simple, but it's powerful. A 2-legged stool is inherently unstable. Relying on spirometry alone, or even spirometry and DLCO without considering the patient's overall functional capacity, is just insufficient, and frankly, it's potentially dangerous. All 3 domains, the mechanics, the gas exchange, and the cardiopulmonary reserve, must be stable and properly assessed to ensure a safe outcome. This slide really lays out the logical, stepwise workflow from the guidelines. Think of it as a cascading algorithm. We start with spirometry and the PIPO FEV1. If those results are borderline, we move on to DLCO and the PIPO DLCO. And if either of those predicted postoperative values dips below that critical 40% threshold, then we must proceed to the definitive assessment of cardiopulmonary reserve with CPET. So, with our comprehensive assessment complete, how does this actually change what we do in the operating room? A thorough workup is really only useful if it directly informs our intraoperative strategy. So now we're going to focus on 2 key physiological principles that directly link our preoperative findings to how we manage one-lung ventilation. First up is hypoxic pulmonary vasoconstriction, or HPV. This is a unique and absolutely vital physiological reflex where the pulmonary arterioles constrict when they sense alveolar hypoxia. During one-lung ventilation, HPV in that collapsed, non-ventilated lung shunts blood flow over to the dependent ventilated lung. This actively reduces the shunt fraction and is the body's main defense against profound hypoxemia in this setting. And this is exactly where our anesthetic choices become critically important. Our agents have a direct and profound impact on this vital reflex. Intravenous agents like propofol and opioids have been shown to preserve HVP. In stark contrast, all volatile anesthetics inhibit HVP in a dose-dependent way, especially at concentrations greater than 1 MAC. This provides a very strong physiological reason to favor a TIVA-based technique, especially in patients who have borderline oxygenation or significant underlying lung disease. Now, while managing oxygenation is a primary concern, we have to simultaneously protect that single ventilated lung from injury. This brings up a critical question. Beyond just keeping the SATs up, what is the single most important ventilatory parameter we have to monitor and control to prevent ventilator-induced lung injury during one-lung ventilation? The answer is driving pressure. It's defined as the plateau pressure minus the PEEP, and it represents the true cyclical stress or strain that's being applied to the alveoli with every single breath. A huge body of evidence has identified driving pressure as the single strongest and most consistent predictor of postoperative pulmonary complications, even more so than tidal volume or plateau pressure alone. Here it is. This is our non-negotiable intraoperative target. The evidence-based goal for lung protective ventilation during OLV is to maintain a driving pressure of less than 14 centimeters of water. Meticulous attention to this number, by carefully adjusting tidal volume and titrating PEEP, is one of the most powerful things we can do to minimize ventilator-associated lung injury. So, to summarize the core principles, first, preoperative risk assessment is a comprehensive 3-part process. It's mechanics, parenchyma, and reserve, the 3 legs of the stool. Second, there are absolute critical thresholds, like a predicted postoperative FEV1 or DLCO below 40%, or a VO2 max below 10, that really dictate operability.
Third, from a physiological standpoint, TIVA is the preferred anesthetic technique to preserve HPV. And finally, our primary intraoperative goal for lung protection is to keep that driving pressure below 14.
So I'll conclude with a question for you to reflect on. Based on this systematic, evidence-based approach, how will you consciously modify your assessment and your anesthetic plan for the next high-risk thoracic surgical patient you care for? Because